You're muted, Blessina.
Hello and welcome to this very important and interesting session on TB preventive therapy. We have with us my co-chair, Mike Frick. I will introduce him in a second. And we also have a lineup of very interesting speakers who will bring their experience and perspectives of the rollout of TB preventive therapy and the uptake and what are the ground realities with regard to this. It's a very important topic. We're very excited that now we have the new drugs that we can prevent TB. This was a distant dream for us, but now it's becoming a reality. And it is for all of us as activists and advocates to push for it so that we know that people can be protected. We're doing well with people living with HIV, but we're really doing very poorly when it comes to children. So I think it's high time for us all to get together, listen to what our speakers have to say, and go back with renewed commitment to ensure that in our own communities, we are able to accelerate the rollout of TB preventive therapy. And it is my absolute pleasure now to introduce Mike, who's a very dear friend and colleague. Mike is one of the co-directors of TAG's TB program. He joined TAG in 2013 as a project officer for TB, and now he leads the TB portfolio focusing on advocacy to support universal access to TB prevention, research, TB vaccines, and he's a great advocate for pushing inclusive research and development, and also recently advocating for a rollout of TPT. And he's very passionate about human rights to ensure that our TB response globally and locally is something that focuses on a rights based approach. And he's got a whole load of achievements to his name. I'm sure you can read it up. It's too long for me to read them all out, but I'm really delighted that he's able to co-chair this session with me. So, Mike, over to you for a few introductory words. Thank you.
Thank you so much, Blessy, for the really kind intro. It's so great to chair this session alongside you. We've worked together for a long time, and I'm thrilled that this panel has a combination that I think is really unique and also powerful. So we titled this session A View from Government and the Grassroots. And basically our idea, GCTA and TAG, when we were planning this, was to have speakers from government and then pair those with community speakers from the same countries and give perspectives on TB preventive treatment, and really do a government community tag team on this topic. So I'm thrilled to have the session today. And I'll just say a few quick words at the beginning, which is that, as Blessy, you alluded to, TB prevention is something that has really come into its own right and become a focus of the TB response. We know we have to prevent TB to end TB. I think a lot of the credit to that is the increasing advocacy by community, which we've been very happy to support under the Impact for TB project with funding from Unitaid and led by Orem Institute. But it's allowed us to bring together a whole host of civil society organizations to work on this topic specifically, and including the partners that we'll hear from today. And GCTA at the same time has been doing great work on producing community treatment literacy materials, convening workshops. So we really have a groundswell of civil society working on TB prevention for the first time, I would say. And this is only the beginning. At the same time, we also know that we can go much farther than we've gone before. And to that extent, it's amazing that we can now prevent tuberculosis in as little as 1 month of preventive treatment with the 1-HP regimen, or 12 weeks taking drugs just once a week with the 3-HP regimen. And this has provided the evidence behind what we're calling the 146 campaign, with that one meaning 1 month of TB prevention making this shorter standard of care available to everyone. So we'll say more about this campaign in the discussion, but just to say that in the global context, this is a really exciting moment to be talking about prevention, and I'm happy that GCTA pulled us together for this. So Blessy, I'll hand it back to you to introduce our first speaker, and we'll get the program going. Thank you.
Thank you, Mike. So as I said, we have a great lineup of speakers, and it is my honor to introduce our first speaker. We couldn't think of anyone better from the government to speak on TPT. Dr. Rajendra P. Joshi is the Deputy Director General looking after the TB portfolio in Ministry of Health and Family Welfare, Government of India. And he has served in many health divisions at the Central Government Health Scheme and Department of Health and Family Welfare. And he is extremely technical person when it comes to TB response. And I have had the privilege of being on several panels with him and really feel encouraged that as a high TB burden country, India, this is the right time for us to actually put all that we have together to ensure that we end TB. And a major part of that, as Mike alluded to, is you need to prevent TB to end TB. So, Dr. Joshi, we are absolutely delighted that you are here with us, and we look forward to hearing your perspectives from the government in the TB preventive therapy in India. Thank you so much. Over to you.
Namaste, greetings from India. I am Dr. Rajendra P. Joshi. I am a National Tuberculosis Program Manager from India. I thank the organizers for giving me opportunity to talk on this August platform, and also for choosing a very, very important topic of TB preventive treatment. In India, since beginning, we had a policy for TB preventive treatment, and up to 2018, we were giving TB preventive treatment to persons living with HIV and household contacts less than 5 years. After the new guidelines, a National Technical Working Group was formed for TB infection. They held 3 meetings in 2020 in spite of the challenge of corona pandemic. And we had a pilot in one of the states in India called Kerala. The results were quite good. The TB preventive therapy was found to be well accepted by the community, and it was found to be safe and effective. So in August 2021, we released the PMTPT guidelines, the Programmatic Management of TB Preventive Therapy guidelines, and preparatory activities started from September. In March to August, we expanded 3RH in 5 states, and now we are planning for scaling up of 3HP and a new skin test called SciTB skin test, which has been validated by independent body and approved by regulatory authorities recently. This is an intradermal skin test which makes the detection of latent TB infection very easy, and this is found to be as good with respect to the specificity and sensitivity compared to the IGRA test. India has got a national policy of programmatic management of TB preventive therapy, where we have got a test and treat or treat policy. The strategy of treat only is for all the patients living with HIV, whether they are taking ART or not, and all household contacts below 5 years of age. For household contacts above 5 years of pulmonary TB and other risk groups who are vulnerable for tuberculosis, whether it is malnourished, patients on immunosuppressant, silicosis, transplant recipient, etc. And for household contact of drug-resistant TB, we rule out tuberculosis and we test for latent TB infection and give TPT. We have got 2 treatment options: 6 months daily isoniazid and 3 months weekly isoniazid and rifampicin in persons older than 2 years. For household contacts of drug-resistant TB, if they are fluoroquinolin susceptible drug-resistant TB, then we use 6 months daily of levofloxacin. For Rifampicin susceptible drug-resistant TB contacts. We give 4-month daily rifampicin. The we were able to clear all the backlog of TB preventive therapy in PLHIV in 2021, and now we are more, moving in a saturated mode. In addition, as you can see from the graph, the household contacts and other individuals who are vulnerable, the number provided with TB preventive therapy has really going up rapidly in this year. We have developed a virtual technology-driven Nikshay TPT dashboard for real-time data monitoring. And with this technology, we are able to monitor closely the implementation of the TPT. The way forward is we have got specific interactions with medical colleges through our national task force. We have got engagement with private sector engagement to address the apprehension in their minds, especially the professional bodies regarding the TB preventive therapy. And multiple meetings, both virtual and physical, have happened, and we plan to continue these things so that everybody is taken on board. We want to introduce the SciTB skin test across India. Ultimate aim is to reach out all the eligible. We want to saturate household contacts. We want to scale up all other vulnerable risk groups, because as the saying goes correctly, prevention is better than cure. Thank you for this opportunity. Thank you all.
Thank you very much, Dr. Joshi, for the presentation of India's updated TB preventive treatment guidelines. I will quickly introduce our next speaker, who is Eldred Tellis. Eldred has become a dear friend of mine. He is one of the community partners working with us on the Impact for TB program. He's the founder and director of Sankalp Rehabilitation Trust, and has nearly 40 years of experience working to promote and protect the health of street drug users in the Mumbai region. He's a dedicated advocate for harm reduction and has won multiple awards for his contributions to the HIV response. We convinced Eldred to come and work on TB preventive treatment and think about ways to bring TB prevention to this population that is especially vulnerable to TB, but often overlooked in programmatic activities. And in addition to all of this, Eldred is a noted expert and activist on access to medicines and has just become a real cornerstone of the TB movement in India. So we'll play the video from Eldred, and then Blessy will be back to introduce the next speaker. Thanks.
Hello and good morning, everyone. Coming from a drug user perspective, and having worked with this key population since almost 40 years, I must reiterate that drug users are an important key population for the rollout of TB preventive therapy. In most of our major cities, these are migrants and homeless, which adds to their vulnerability. Active street-based drug users will never prioritize nutrition and are often undernourished. Therefore, an exercise to map vulnerable communities is urgent and imperative. It is pertinent that the regimen prescribed is less toxic, of shorter duration, and therefore easier to adhere to. It is well known that the WHO recommended 12-week regimen of 3HP decreases pill burden, is shorter in duration, and promotes better adherence. In fact, we at Sankalp had been promised 10 case studies, the drugs for these 10 case studies by our city TB office. And this would have provided us a good idea of completion rates. But sadly, it's been 8 to 9 months and we still haven't received these. This is also an indicator that the availability is not as much as it should be. There was a recent announcement by Unitaid, the Aurum Institute, the Clinton Health Access Initiative, and MedAccess of agreements with manufacturers, McLeod's, and Lupin, both of whom have their bases in India, for price reduction of 3-HP in 138 low and middle income countries. Yet we in India, who pride ourselves as being the pharmacy of the developing world, cannot make sure that our own citizens get the treatment they need. It's a pity. In South Africa, they have rolled it out in 2021, while we here, home to the manufacturers, are lagging behind. We must also learn that procurement is vital in the rollout, and there cannot be stockouts as we have seen in the HIV/AIDS program. We have seen how lack of supply can cause dropouts of treatment, which in turn affects the success of the initiative. Therefore, planning in procurement is of utmost importance. We've already seen the case of Bedaquiline, where the government accepted 10,000 doses as a gift from Johnson and Johnson. And because it was not enough to go around the whole country, it was limited to 2,000 doses to the 5 big metros. Suffice to say, there were people who needed it from outside these metros. And a case in point is that of Shreyas, a young girl who came from outside of Delhi to access it, but was denied the drug because she did not have a domicile of Delhi. Of course, she went to the courts, fought a battle, which was lengthy, 1.5 years. By the time she got a verdict in her favor, it was too late. She passed away. Will our planners take the responsibility for these kind of deaths? It's a question mark. Another good case in point is that of Delaminate, where there's a huge gap between what is required and what is available. But this should not happen with TPT, and the rollout needs to be smooth. Efforts towards the elimination of TB must be people-centered and tailored according to the need of diverse populations, especially high-risk groups such as the homeless, migrants, and drug users. Thank you.
Thank you very much, Eldred, for sharing that with all of us. Indeed, it is going to be hard work for us, but we all need to get together to ensure that TPT is rolled out in our country at the earliest. Our next speaker is Dr. Jacqueline Kisia Niale, who is from Kenya. She is the head of Division of Tuberculosis, Leprosy, and Lung Disease Program. She has interest in public health, having worked in both National Malaria Program and National TB Program for the last 12 years. Previously, as the head of the care and treatment and the focal point person for childhood and adolescent TB program in Kenya. And we have also worked very closely with Dr. Jacqueline. She has been a panelist for many of our TPT trainings. So it is, I'm really delighted to invite Jacqueline right now, and we'll play the video. And of course, the speakers will be available for comments and answering question and answers towards the end. Thank you. Over to you, Jacqueline.
My name's Dr. Jackie Kisia, head of National TB Program, Kenya, and I will be taking you through TPT implementation status, the Kenyan journey. My presentation will have the background information, what we have done, what we have achieved, our challenges, and what we require. TB prevention therapy has been identified as a component to end TB strategy by WHO. So Kenya participated in 2018 in the UN high-level meeting and committed or had a target to reach up to 900,000 persons and put them on TPT. To achieve this, we had to review the WHO guidelines on TPT and contextualization, identify and prioritization of target group for TPT and the regimen, resource mobilization, and also draft the implementation roadmap, development of the TB infection policy guidelines, and recording and reporting. What has been done so far? We have developed our LTBI policy and we launched it in 2020. During this launch, we had political goodwill by the attendance of the Chief Administration Secretary of Health, our Kenya representative, WHO WR representative was in attendance. We also had a country representative of the Clinton Health Access, which supports heavily in TPT in Kenya, and our head of program, NTP, and other organization or partners were in attendance. What has been done so far? We have developed our TPT guidelines. We have also developed our job aids and also training materials, slides for training, and also updated our tools and aligned them with the national TPT indicators. We have also uploaded electronic tools for data capture and reporting, that is TIBU. We have also had a training of healthcare workers. Out of the 47 counties in Kenya, we have trained 42 counties, and out of the 45 counties which have received support. The target population which we want to reach out to is the people living with HIV, all household contacts, patients who are preparing for organ transplant, and segregated setting, that is the prison, or and the healthcare workers. So far in this target group, we have reached out or started over 293 clients who are HIV positive, and also reached out to household contact, that is over 28,000 patients who were preparing for organ transplant, up to 29 patients, and segregated setting. We have reached prisons and healthcare workers, just about 4,000 clients. Our recommended regimen, we have the 3HP given once a week for 12 weeks, targeting above 15 years, regardless of their status, whether they're HIV positive or negative. The 3RH given daily for 3 months, targeting children below 15 years who are HIV negative, and 6H given for 6 months, children living with HIV, pregnant women, and those who cannot tolerate 3RH or 3HP. Our challenges are putting household contacts on TPT. There is a low uptake in adults, and flow of 3HP in the country has been low. Coverage for trainings of healthcare workers is not complete in 5 counties. Delay of printing and distribution of guidelines and job aids inconsistency in reporting by healthcare workers, and also distribution of commodities. What is required? Resources to conduct data review meeting with counties, track progress and address challenges. We also need technical support at the county level to assist in monitoring the data quality checks, and also advocacy to demand creation in the community to improve TPT uptake. Thank you, and that is the journey for Kenya.
Thank you very much, Dr. Kisia, for overviewing the TPT program in Kenya. We're next going to hear from a dedicated advocate for TB preventive treatment, Stephen and Guva Shikoli of the Pamoja TB Group, also an Impact for TB community partner. Stephen is also the national coordinator of the Network of TB Champions in Kenya and a real advocacy force there. As it happens, Blessy and I have both had the chance to visit Pamoja TB Group and see Stephen's work in the Kangemi community and at Kangemi Health Post this year, and know firsthand the wonderful work that he's doing on the ground there as an ambassador for TB prevention. And Stephen has won a whole slew of awards, a PEPFAR champion in the country, also serves on community advisory boards for HIV and TB prevention research, and just from research to practice has been an instrumental partner and really leading the way on TB preventive treatment at the community level. So we'll let the video from Stephen play, and then Blessy will be back to introduce the final recording. Thank you.
Thank you very much for this opportunity to talk about TPT implementation at the country level from the community perspective. My name is Stephen Anguva Shikoli. I'm the director of Pamoja TB Group in Kenya. I'm also the national coordinator network of TB champions. So in terms of our progress that we've seen made in the country, engaging TB affected communities at the grassroots level is the only way to end TB. The disease is at the community, therefore funding community intervention will help the world find missing people with TB. As an organization, we have been able to widen the partnership with other players, bringing on board colleagues from the tobacco control who are willing to use their platforms to create more awareness on TB prevention. By the use of World Health Day, example World AIDS Day, World TB Day, and International Candlelight Memorial Days, we've been able to create awareness on TB prevention and increase demand for the new short course regimen. Pamoja has managed to train 72 community health volunteers and 87 health workers on short course TPT, as well as on importance of documentation. Pamoja is now engaged at the National Latent TB Infection Committee of Experts, COE, where we are able to provide feedback on service provision and advise areas we need improvement. We believe integration of tuberculosis prevention into the mainstream health program has proved success as the community now access preventive treatment in their respective department. We've seen several gaps in the implementation, such as insufficient development of IEC materials on TB preventive treatment. We have very few materials that are developed in the country. Inconsistent supply of TPT in the country. There is high demand with low supply with regular stockouts. Limitation of eligible population who can be given TPT in our community. We've seen some population being excluded, for example, the drug users, and when we go to the community to create awareness, there is a high demand for them to be initiated on TPT, but because of eligibility, they are left out. Then there is a low knowledge among healthcare workers on new short course of TPT. They still measure on INH, so therefore the new short course training, they have not been trained, most of them. Lack of auxiliary medicine to cater for side effects. You get that when when people are on TPT and come with their side effects, they are not able to access management of the side effects. We have a few recommendations as the community. So there is larger need to invest in communities who are the wheels to find and end TB in the community and in the world. Regular training for TB affected communities and updates on new emerging innovation in the TB world. World leaders need to commit resources for research and development in the TB space and accelerate prevention intervention. BCG is now less effective. Being more than 100 years old, it cannot help. The community need a seat at all levels, from policy guideline development, implementation, and evaluation. In all countries, our voice matters. Thank you very much. Asante sana. These are some of the pictorial of our activities.
Asante sana, indeed, Stephen. That was very interesting, and thank you for sharing that with us. I'd like to now introduce Paran. Paran Sarimita Varnani is from Indonesia. She brings with her the lived experience of both drug sensitive and drug resistant TB, MDR TB, and which she suffered in 2012. And since 2014, Paran has been an active advocate and has led the patient organization called PETA, and which brings MDR TB survivors to advocate for better access and ensure that there is a place for people with the lived experience at the table to shape policy. She's also very passionate about TB prevention and has been instrumental in implementing one of the projects for TB preventive therapy. And she is also the uh, Global TB Community Advisory Board member, and she's also the Southeast Asia Regional Green Light Committee's vice chair. So, Paran, over to you now. Thank you very much for being here with us.
Before I deliver my presentation, I would like to say thank you to Global Coalition of TB Activists that already invite me as a speaker in this very important session at Community Connect. My name is Paran Salim Tawinarni and I'm from Indonesia. So from the previous presentation, we can recognize that we have challenge at the government level and also community level. So this is all the challenge at the government level that I can bring to all of you. Like we already know, UN General has assembly high-level meeting on ending TB in 2018, have high-level commitment, but now how it's the implementation in the country, how where we are now, and TB is beyond health issues. So how about the cross sectors commitments? And also for the invest in community, for CSO and affected community. Is it non or limited? The other government challenge is commitment on TB prevention. It's absent of the regulation and guidelines and procurement and supplies issues. And we also have a lack of quality health services and human resource. Some still do not believe in benefit of TBT. So beside the government level, we also have the challenge at the community level. The community has strategic rules, but inadequate capacity like knowledge, skills, and it leads into a low trust of people to CSOs. Less harmonized relation with health facilities and health carers, and less involved in government-related business. And it also lack of support financially, technically, and access to services like economically and geographically. How we can do to way forward for this challenge? The first one is invest more, not only from the global commitment, but it's also country commitment and also local commitment. But once again, commitment is not enough. It has to be bring with also the action. And the action is improve health-related service quality, ensure guidelines are implemented, embrace community, and build the capacity and skills. Put once again the patient at the centers of TB response, because we all know that patients are part of the solution. And involve the community at any level of program planning, and also consult community for the policy guidelines and develop. So involve community not at the end of the planning, but we have to involve them at the start from the planning. So, and then we have to reduce price and drugs and regions, increase drugs and regimen production according to the needs, and explore new TB vaccine development. We also have to create a community-friendly feedback mechanism. So last but not least, it's always I always say that nothing about us without us. Thank you.
Thank you very much, Farhan, for that. And I see that there are a few comments and questions. If the speakers would like to switch on their videos and mute yourselves when you're not speaking, but there are some questions specifically for speakers. If you would like to come in, I think quite a few questions are for Dr. Jacqueline and for Dr. Joshi. I'd ask Dr. Joshi to go first, please. Thank you.
And I think the particular question for Dr. Joshi, one that showed up in the Q&A was plans for introducing the 1 HP regimen alongside 3 HP in India. And I think that's a great question maybe for Dr. Kisia as well. So I don't see them on video yet, but if you two are there and are able to answer, we'll give you a second for the technology to catch up to you. I know we were having some connectivity issues earlier, and I don't see either of our esteemed government colleagues on video yet.
Yeah, I don't
Shall we
think.
move on, Blessy, while we wait for them and hope to get them connected?
Yeah. Yes. Yeah.
So one thing, the common thread across all the presentations was this issue of availability and supply and planning and procurement. And Eldred, you very rightly contextualized this by saying that the challenges with TB preventive treatment supply are not unique to prevention, that we've seen low supply for other TB commodities like bedaquiline and delaminid, that low supply creates scarcity. That scarcity means we have to write more narrow guidelines, that we can't cover the whole country, that we have to leave people out of treatment. And these presentations, both from government and community, indicate that that effect is also playing out when it comes to TPT. We just haven't had enough 3-HP, enough rifapentine to make it available at the scale that we would like. I'm wondering if you can comment on what you think needs to be done, actually, say a bit more to ensure supply security, which is a part of ensuring equity in TB prevention. And maybe, Eldred, if we can start with your thoughts, and then we'll go to Stephen and Paran to see if they want to add on to that, because I know they've had challenges in Kenya and Indonesia as well.
I'm not in the best position to advise our government, but it's just that being in the HIV/AIDS field, I have seen the harm it has done. In fact, recently we had a really very big issue on stockouts and HIV, and we had these positive people networks sitting out there for almost 6 or 7 weeks, to get some action, and it was rather stressful for us, even though we were not sitting out there, because we know how it's affecting the huge numbers of people who require these drugs. And it's just taking a cue from what's been happening in HIV. I felt that the government really needs to get its act together in terms of planning and procurement, because sometimes we find later that they've accepted code from some blacklisted agency, and it takes another 3 months to do the whole routine again. So it's just the whole the way it's done has to be streamlined. That's all I can say. Because if you're going to be responsible for something, and we in India we're talking about, wiping out TB by 2025, it's like very far fetched if we continue the way we've done with HIV.
Thank you. What about you, Stephen? Are you able to unmute? There you, yes, I think that's working. Let's see.
Yeah, thank you very much, Mike, and thank you very much, colleagues, for joining this our session. I think we are very privileged to have more than 80 of you joining us. This is wonderful. This shows that we all are in the prevention part of our lives, and it is very critical. So, to the question of in terms of supply, the erratic supply, I think it's upon our governments and especially the TB programs to ensure they are doing proper programming in terms of planning in advance, looking at the prevalence. I know we all know our country-specific prevalence, so if we plan with that in mind, then we are able to manage. And also, I will not stop without saying the issue of domestic resource mobilization. I think it's high time that our elected leaders look at TB as the burden of the country, not just the burden of the TB program. I think it's high time we set aside money for prevention, because we believe if we prevent, any investment we put in line to prevent TB, then we will have success in future and we will have less burden when it comes to treatment. I think it's all about programming, mainstreaming, and engaging everybody at the table, from the community to the government and to the elected leaders. That's what I can say for now. Thank you.
That's great. We have a couple of questions about TPT for household contacts. And I would like to hear now from people about what you think are some strategies. And since we have our community speakers on video, we'll talk from the community perspective in these final minutes. What are some strategies for broadening TB preventive treatment outside of ART clinics, looking sort of beyond this people living with HIV group, where we've actually met our global target and had more success than other areas? But how do we expand TPT within the household and work with people who are HIV negative? Any thoughts on that? We know Kenya's started to do it. We saw the statistics Dr. Kisia put up. India has big plans for this as well. What's the early experience been like? And it's being done in Indonesia too. So Paran, maybe we'll start with you on household contacts, and then we'll go Stephen and Eldred and close it out that way. Paran, let us know if you're able to unmute.
Sorry, can you because I don't know if it's in here, it's the network, because it's very rainy in here, so I cannot clearly hear your question.
The question was TB preventive treatment and household contacts and strategies for expanding it in that group. We can come back to you to give you time to think. We'll start with Stephen, and then we'll come back to Paran and Eldred. Go ahead, Stephen.
Yeah, thank you very much, Mike, and thank you very much, team, for that question when it comes to contact. I think line listing is very critical when somebody has treatment, and we need to support the intervention that are geared toward line listing, and also engaging the TB-affected communities to go and support in creating awareness about the importance of TPT. So if we do line listing, we have a snapshot of the number of people that might be expected to start TB preventive therapy. So I think it's all about strengthening the line listing component, and also empowering our healthcare workers to ensure they are able to line list all contacts of people that are having TB. I know in Kenya we've started with contact of bacteriologically confirmed, but we can even expand. I think resources should be set aside to expand, because today you might be an extrapulmonary TB, maybe in the next 1 year, you don't know if you're exposed, you might develop pulmonary tuberculosis or you might develop back TB. So I think it's all about engaging everybody and ensuring that we are doing line listing and supporting intervention toward line listing to ensure that we know and we plan for the people that we're expecting to come in the clinic and to make sure that we have available treatment ready for them. Because if we line list and the treatment is not at the facility, then people will come and they will not be able to access the treatment. So let line list and ensure that there is commodity security, that we know we are anticipating this number of people, this number of contacts that should be able to be put on TB preventive therapy. Thank you.
That's great. And Paran, we're running short on time. We're hearing from the tech team. So Paran, we'll give you the last comment on this. Please go ahead.
Okay, apology for my network. So I think with increased TPT in household, we can give education to the mothers or whoever decision makers in the family, and then about the benefit of the TPT itself, not just for the nuclear family, but also extend family. And then we can, as a community, advocate to the at least local health facilities and building mutual relation. Yeah, I think because nowadays is TPT, it's most of this doing and managing by the government, not for the community. You know, the community is more closer with the household contact, with the patient, with the children and everything. So I think we can also give the opportunity to do the TPT for the community, do by community, not only for government or health workers only. And then at the same time, we help health facility to improve their performance in TPT. I think those that I can add for the question. Thank you.
Blessy, home.
Yeah, thank you very much. We're getting prompts. We have just a few minutes, but I just wanted to say a big thank you on behalf of the Global Coalition of TB Advocates and Treatment Action Group for this amazing session. We had over 100 people at one point. So I think it is, the time is really right. And I think if we look at the TB response as people-centered and rights-based, I think this will become, when there is prevention available, it would be a violation of individuals' right to access to that if we don't provide it. So I think as we advocate even with our programs, I think this is something we should take forward. And as Mike mentioned, GCTA, we are working on this. Both Eldred, all three of them, Eldred, Paran, and Stephen, have been part of our trainings on TB preventive therapy. And of course, Mike remains a guide and mentor in this area. And we really hope that people who need it would be able to access it without all the challenges, and drugs would be made available. I think no more excuses. It's time for us to really move forward so that we can jointly contribute to ending TB at the earliest. Thank you very much.